Tac. Bon, donc bonjour à toutes et à tous sur cette masterclass, la première de l'année universitaire 2024-2025. On a l'honneur et la joie de recevoir professeur Kirmayer. On vous propose de faire une introduction en deux temps, de commencer par vous présenter avec Tudy le DU de philosophie de la psychiatrie dans lequel cette masterclass a lieu. Puis j'introduirai euh, professeur Kirmayer pour lui laisser la parole pendant environ 45 minutes et pour pouvoir ensuite échanger avec lui.
Alors, on va vous demander de couper les micros. Jean, on vous entend. Billy, je vois que votre micro n'est pas coupé. Pascal, Denis, également, si vous pouvez. Voilà, merci pour la meilleure qualité d'écoute. Merci à toutes et tous d'avoir pu nous rejoindre ce soir. Cette masterclass a lieu dans le cadre du diplôme interuniversitaire de philosophie de la psychiatrie. C'est un diplôme qui est coporté par les universités de Bordeaux, et notamment le professeur Jean-Arthur Micolo-Franchi, à l'université de Toulouse par moi-même, et à l'université Aix-Marseille par le professeur Michel Sermolach. Euh, voilà. Prochaine slide. Donc, ce diplôme interuniversitaire, il a lieu sur 12 jours pour 120 heures de cours, avec donc trois séminaires de formation et un séminaire et une école d'été. Un premier séminaire qui a lieu en début d'année à Bordeaux et qui porte sur les questions de philosophie des sciences et également d'épistémologie, alors que ce soit épistémologie des classifications, mais également épistémologie de la psychiatrie. Laurence est en train de nous dire qu'il ne voit pas les slides.
Ah, euh, les autres, vous...
Ouais, moi je vois. En tout cas.
Oui, d'accord.
Ok, d'accord. Ok.
Ensuite, un séminaire à Toulouse en distanciel qui porte sur l'introduction à l'approche phénoménologique en psychiatrie, avec notamment un focus sur l'expérience vécue du corps et de l'expérience de soi, notamment dans les troubles psychotiques, ainsi qu'une introduction aux psychothérapies d'inspiration phénoménologique. On poursuit le troisième séminaire à Marseille, qui est un peu la confluence des deux premières approches entre science et subjectivité. On s'interroge sur finalement comment est-ce qu'on peut imaginer une science prenant en compte l'expérience subjective, que ce soit en recherche qualitative, mais également avec une introduction au courant neurophénoménologique et encore quelques travaux autour de la psychopathologie phénoménologique. Et puis, tous les ans, on organise une école d'été dont les thèmes changent chaque année en fonction d'un curateur que nous invitons pour nous challenger, en fait, en quelque sorte, sur des thèmes qui sortent un peu de nos habitudes. Et cette année, pour vous donner un exemple, c'est Istvan Fazakas, qui est philosophe et qui a proposé une masterclass sur la crise épistémologique de la psychiatrie et les imaginaires des futurs possibles, ce qu'on a appelé aliénisme spéculatif. Ça a lieu à Toulouse. Voilà, donc 120 heures de cours pour un programme qui s'articule entre épistémologie et phénoménologie de la psychiatrie. Si vous souhaitez voir le programme, éventuellement vous inscrire pour l'année universitaire 2026, on vous invite à passer par le site internet. Donc vous avez l'adresse là-haut, philosophiepsychiatrie.wordpress.com. Et sur le site, vous aurez les instructions pour l'inscription. Ce qu'il faut bien comprendre, c'est qu'il y a d'abord un processus d'inscription administrative, pardon, pédagogique, justement. Dans un premier temps, vous nous envoyez un CV et une lettre de motivation court pour que nous vérifions que vous remplissez les critères pour l'accès à la formation. En gros, c'est le niveau master qui est attendu. Et puis à partir de là, on vous répond sur le fait qu'on prend bien en compte votre inscription et c'est nous qui vous dispatchons entre l'une des trois universités. Donc ne contactez pas directement l'Université de Bordeaux, de Toulouse ou de Marseille. Contactez-nous d'abord et ensuite on vous dispatche pour qu'il y ait une sorte d'équité entre les trois universités, ce qui nous permet d'avoir des financements qui permettent de tout financer. Voilà. Et également, vous trouverez le programme que je viens de vous présenter si vous voulez l'examiner avec plus de détails. En gros, l'année prochaine, ce sera sensiblement la même chose, avec probablement une masterclass qui s'orientera autour des perspectives écoféministes et décoloniales en psychiatrie. Voilà, c'est probablement ça. Ça risque de changer. Voilà pour le DIU.
Et le DU, donc, qui est accessible aux personnes qui sont inscrites avec les modalités qu'on vous a décrites, se couple de masterclass, du coup, en accès libre, pour pouvoir discuter d'un fil rouge autour de thématiques qui changent chaque année et de personnalités qu'on fait venir pour aborder la philosophie de la psychiatrie de manière originale. Donc voilà le programme de des masterclass cette année. On est très heureux de commencer avec professeur Kirmayer, mais on continuera avec Alexis Revet de Toulouse sur les humanités médicales dans la formation, Jérôme Anglebert sur le Rorschach.
En septembre,
Euh,
pardon, excuse-moi.
oui,
Alexis Revet, en fait, il m'a confirmé que c'était en septembre. Alors, j'ai plus exactement la date, mais on le fera pas en mars.
d'accord, donc ça sera en septembre pour Alexis Revet. Mais les autres dates sont confirmées. Jeudi 10 avril, le Rorschach comme échantillon de l'être au monde, donc une phénoménologie du Rorschach. Yves Sarfati, le jeudi 15 mai, sur l'intersubjectivité et la copensée, il va sortir un livre sur cela chez Vildoché. Et Jean-Philippe Pierron sur l'approche sensible. Et donc pour les étudiants du DU, par rapport à votre plaquette, vous avez les dates mises à jour qui ont été confirmées et on vous donnera la date de septembre. Ça sera un jeudi en septembre. Pour cette masterclass, donc on ouvre avec euh, professeur Kirmayer, mais vous avez le programme ici des flyers pour chaque masterclass. Ça seront sur les mêmes formats à chaque fois. C'est-à-dire qu'à chaque fois, il y aura 45 minutes de présentation, 1 heure, et puis un moment d'échange où les étudiants du DU ont la primeur des questions, mais où chacun peut poser sa question, soit en oral, soit par chat. Mais l'idée, c'est de pouvoir laisser d'abord les étudiants du DU qui sont inscrits, mais que la parole est ouverte, et le faire systématiquement de manière constructive avec l'orateur qui est là et en s'écoutant réciproquement sur les questions qui sont posées par chacun. L'idée n'est pas de faire un débat contradictoire, mais essayer de penser avec la personne qu'on invite. Donc la personne qu'on invite aujourd'hui est le professeur Kirmayer, qui est de la division de psychiatrie sociale et transculturelle à McGill Université. C'est une figure majeure de la psychiatrie culturelle et de la pensée transculturelle dans le champ de la santé mentale. Il travaille sur la psychiatrie et l'impact du contexte culturel sur les maladies mentales, leur expression, leur phénoménologie, si on peut dire leur sémiologie, dans une approche narrative et culturelle. Et il propose ainsi de penser à un modèle intégratif des soins fondé sur une perspective fondamentalement ouverte sur nos pratiques cliniques et théoriques en psychiatrie. Alors, il est l'auteur de nombreux articles, mais j'ai mis ici ses ouvrages, un textbook qui est vraiment, je pense, d'importance dans le champ de la psychiatrie, qui s'appelle Revisioning Psychiatrie. Il est éditeur de ce textbook. Euh, un livre sur la consultation en prenant en compte les critères culturels et un ouvrage prochain en juin 2025 à Cambridge University Press qui s'intitule Healing and the Invention of Metaphor Toward the Poetics of Illness Experience. Et pour information, Laurence Kirmayer est aussi celui qui participe à la section culturelle dans le DSM, je crois depuis le DSM 4, 4TR, 5, et donc sur cette place importante qu'on pourrait oublier, mais que le DSM réfléchit aussi à cette approche culturelle de la psychiatrie. Alors on est très heureux, Laurence, on te laisse la parole et de pouvoir t'écouter depuis la France et peut-être d'autres régions. Il y a peut-être aussi des Canadiens parce que l'annonce a beaucoup diffusé. On vous propose vraiment de couper vos micros pendant la session. Xenia, je vous coupe le micro, donc je le ferai arbitrairement, enfin autoritairement, enfin par le choix comme ça. Et après, un moment d'échange avec Laurence. Merci beaucoup d'être avec nous.
Oui, merci beaucoup, Jean-Arthur et et tous les autres. Je suis très heureuse d'être ici avec vous dans cet espace virtuel. Comme vous avez déjà indiqué, je vais parler en anglais parce que c'est beaucoup plus facile pour moi, comme vous voyez. Mais c'est possible que vous pouvez poser des questions, des commentaires en français après mon présentation. So thank you very much. It's really a pleasure to be here, and I see many friends from different parts of the world online. We advertise this on our listserv also, so that's an added treat. But I'm very glad to be able to engage in some conversation with you around some ideas about what it is we're trying to do in psychiatry. And given that this is a context of thinking about the philosophy of psychiatry, I want to step back a bit from what we do and try to offer you some frames for thinking about that that come from the perspectives of cultural psychiatry in particular. And I'll explain more about what I mean by that in a moment. So broadly speaking, these are the objectives of my talk for the next while, to talk about the place of the social and cultural in human functioning, in health and illness, to outline what we're calling, for want of a better, a more concise term, a cultural eco-social systems view of human functioning in health and illness, and therefore an approach to psychiatry. Um, and it says here, it might have switched to a different language. No, anyway, okay, I'm going to cancel that. That was just a private message to me. And and then to draw out some of the implications for research and practice. And I should say just a word about the context that I'm coming from. I direct a program at McGill that goes back to the 1950s that started as a partnership between anthropology and psychiatry, driven by the fact that many people were coming to McGill from different parts of the world, especially former Commonwealth countries, for training in psychiatry, and they raised questions about how well the the material that was being presented, the prototypical description of a patient, and so on, how well that really fit the realities that they encountered in different parts of the world. So that was viewed then as an opportunity to use the global nature of mental health practice, the comparative method, to raise substantive questions about psychiatry. And so at that time, Eric Whitcower and then eventually Ray Prince and Henry Murphy started this division of social and transcultural psychiatry and a journal, Transcultural Psychiatric Research Review, which is now Transcultural Psychiatry, for international exchange and reflection on the nature of mental health problems, foregrounding culture and context. And as John Arthur has already mentioned, uh, most of what I'm going to say is reflected in various papers that I've written, which I'll mention along the way, and these books that collect a lot of work by different people from whom I'm drawing to sort of make the arguments for today. So we'll come back to that. So when I talk about culture, I'll say more about what I mean by that. But I think that the fundamental point that I want to underscore is that we are all cultural beings. We depend on growing up within a social world that profoundly shapes us. Mentally, physically, socially, and that is then reflected in many different ways in the practice of psychiatry, from the basic questions about what people experience when they're having a mental health problem, to our understandings of what the underlying mechanisms might be of a problem, to the social contexts that give rise to problems, to the basic task in clinical settings of communicating with people to make sense about what's going on and then intervening, and then to the ways that we intervene that need to respect the life worlds of people that are embedded in different value systems and that raise issues of human rights and politics. And I'll come back to that at the very end because we're at a particular moment in time when cultural psychiatry, which for many years seemed like just a positive gesture toward living in a more pluralistic and inclusive society that we were gradually moving toward, and partly as through efforts to sort of move past the colonial inequalities that really shape our world, is now that benevolent view of where we might be heading, although we're never there, is now very much under attack from the political right in many places, notably for us in Canada, just south of the border in the US, really catastrophic things are going on. So it's hard to talk about any of this without keeping that in mind and then trying to see if we can draw anything from what we're talking about that would help us to make sense of this and respond and resist to the some of the difficult things that are happening. I'm going to, because this is a course in philosophy of psychiatry, I'm not going to do just a sort of straight ahead discussion of social and cultural issues. I want to frame it maybe more fundamentally in terms of questions of ontology and epistemology. That is to say, what it is we're looking at, what there is in the world that we're trying to make sense of, and the ways in which we can know what's going on, the ways in which we can gather knowledge and make sense of things. So I'll just say that the word ontology is used in many different ways nowadays, one of which corresponds, or one set of which corresponds to sort of the classical phenomenological view of ontology in philosophy, in European philosophy. But there are other views, other uses of the term that are important to us in psychiatry, one of which really comes from information sciences and attempts to describe the nature of scientific knowledge, in which people are constructing ontologies that are essentially classifications and categorizations of scientific objects in some ways. So that's an interesting issue for us in terms of just the basic question for psychiatry. What is it that we're studying? What is a psychiatric disorder? What is a psychiatric problem? What is a psychiatric symptom? These are semiotic questions, but they're also ontological questions in the sense of what do we think is really going on behind the things that we can know. Another use of this term that's relevant to what we'll be talking about has come from a movement within anthropology in the last 20 or 30 years that's been called the ontological turn, to take more seriously the very different life worlds that people occupy in different cultures. And rather than simply translating it into a Western Euro-American kind of ontological frame or a scientific ontological frame, to see how far we can go in entering into a very different kind of world and thinking within that world. So this is a serious challenge. I think there are all kinds of dilemmas around that in terms of social sciences. Clinically speaking, we have a more modest view of this, a more immediate task, which is simply trying to get a bit of a grasp of the life world of the individual in front of us, which requires that we make some sense of where they're coming from, of the world that they live in everyday life, the world they're going to return to after they step out of our office. And so in that more limited and more focused way, there are things that we need to understand that we could also call ontology. So I'm going to be pointing toward all of those uses as we go along and try to introduce this more social way of thinking. Now, we should say, if you take that first view of the objects of our science or our bodies of knowledge, then we can talk about the ontology of our diagnostic systems. So if we look at the DSM or ICD, for that matter, I think somebody has their, yeah, thanks a lot. Then we can sort of ask what implicit ontology, to some extent it's explicit. There are a few comments in the introduction and various places that point toward a particular ontology, but a lot of this is implicit. And what it suggests is that what a mental health problem is, what a psychiatric disorder is it some kind of a problem, social problem, personal problem that is related to a dysfunction, to something not working right, and that is located within the person in some sense. Nowadays, very much framed in terms of it's located inside their brain, in the past located in their psychology, wherever that may be. And part of what I want to do is push back on that a little bit and suggest that there are many places in which problems can be located, including in the social world and especially in our relationships to the social world. And we need to include that in our ontology of psychiatry. So that's part of where we're heading in some ways. But to the extent that we frame mental health problem as something that's located in the individual and located in the confines of their skull or in their psyche, then it's natural that we'll have a nosology that just describes those kinds of problems, and we'll think of interventions that are focused on the individual in that way. So this these ontological assumptions about what a mental disorder is, what a psychiatric disorder is, are important because they, in a sense, already format or already circumscribe the kind of information we're going to collect, the kind of formulation we make, and the kinds of interventions we do. So this is, again, points to the very practical reason why we may need to be enlarging our understanding of what we're trying to do and what resources we have for doing it. I should say that the DSM and John Arthur already mentioned this, that starting with DSM-4, the DSM has paid some attention to the idea of culture. Actually, in DSM-3, as the book was getting ready to go to print, Robert Spitzer called the psychiatrist anthropologist Arthur Kleinman and said, "Could you write me something about culture for the introduction?" So that was how serious the engagement was with culture in DSM-3, and there's a paragraph or two there that Arthur Kleinman wrote. In DSM-4, there was a consultation process. I noticed Renato Alarcon was here and other people here who may have participated in that, that involved about 100 people with parallel groups addressing all the disorders being talked about in the DSM from a more social cultural point of view. Most of those people came from within the United States, so there was a limited, I see Juan Message here, who was a leader of that whole process. Very nice to see you, Juan. And very limited representation from outside the United States and a certain amount of pushback about how relevant these broader discussions of culture were, but better views prevailed, and there was some serious effort to try to incorporate culture in the DSM. However, in that context, DSM sort of inherited an older view of culture, which again largely ends up locating culture inside the heads of people, that it's beliefs and values and attitudes that people have, and that you can ask them about. They can tell you about their culture, and you'll fill in the blanks in some ways. And that's reflected in what happened in the DSM in terms of developing an outline for cultural formulation, and eventually with DSM-5, a cultural formulation interview that was meant to demystify the process of collecting basic information, to show that it's not extremely difficult, that you can begin to collect information just by inquiring into it, and in that way begin to flesh out this more situated or contextual view of the person, nevertheless seeing culture as something that is carried by the individual in some way. And that's partly true, but it's also true that a lot of culture resides in the social world. It resides in the material structures of the world. It resides in relationships with other people. It resides in institutions and practices. And we are all affected by that. And we all know some of that, can talk about some of that, but a lot of that, the largest part of what affects us and shapes us, is not something we can easily talk about. It's something that has to be observed, that has to be learned about, that has to be made visible by comparison. So that sets limitations on how well we can fully understand another person's culture or life world simply from interviewing them. We need other sources of information to begin to make sense of their background, of their everyday kind of circumstances. And that's, again, a theme I'll be returning to. So I should say also that this initial process of beginning to take culture seriously in the DSM, and we could talk about a parallel process that happened in ICD with different pressures, but in the context of the US, this was driven a lot by the local demographics, what we could call the politics of diversity in the US, and in particular by a substantial number of Hispanic or Latino psychiatrists, mental health practitioners, and a population that was pushing for greater equity both within the profession and in healthcare. So there was a political basis for beginning to pay attention to these things in some significant way within existing nosology and practice. At the level of international psychiatry and the ICD, the politics are clearly different in many ways, and you had some voices from the global south, but also delicate issues around the need to try to generate universally applicable tools with very modest resources. So there was a limited effort to incorporate cultural difference in the ways that ICD evolved at many points. And we can come back to some of that history perhaps at some point if that's of interest. So that was sort of the situation in the 80s and 90s, and but in the meantime, psychiatry has invested ever more seriously in the possibility of getting neurobiological explanations for mental disorders. And we had the decade of the brain and another decade of the brain, and somewhere in there we had a decade of the mind, but it was eclipsed by another decade of the brain. And we basically have had a lot of neuroscience research, fabulously interesting things produced, which, however, have had relatively limited impact on the practice of psychiatry. So surprisingly little for the amount of effort that's gone into it, I would say. Um, and more recently, there was a hope with DSM-5 that the whole nosology would be reconstructed on the basis of neuroscientific information. And as that process began to unfold, it quickly became clear that we were nowhere near having the kinds of science we would need to do a proper job of that. And so the revision ended up being quite conservative. In fact, one of the more innovative things was the cultural formulation interview, and the DSM-5 and APA ended up making a big deal about that simply because they had relatively little other new stuff to promote the book with, I would say. In the meantime, the US NIMH developed another approach to funding research on the basis that the attempt to find discrete disorders on a just phenomenological or really just descriptive kind of basis that the DSM had set up was not producing clear neurobiological explanations, clear mechanistic explanations for disorders. And so the NIMH launched this RDoC program, the Research Domain Criteria, to try to get people to focus on different kinds of underlying processes that could be analyzed at multiple levels. So this is a paper that critiques the RDoC, not for what it does, but for what it doesn't do. There's nothing wrong with going and using animal models about things and trying to understand using the best available neurobiology to make sense of mental disorders. It's just that there's a lot more stuff going on for people than is captured in animal models. We don't have a mouse model of being a refugee or of having a transracial adoption or of having an existential crisis, as far as I know. Anyway, maybe a mouse can have it, but it's back to that famous line from Wittgenstein: if a mouse had an existential crisis, we probably would not be able to understand its expression of it. The problem we have is the RDoC developed this interesting grid. The rows represent areas of science where there are well-developed models and interesting things going on. Tom Insel, who promoted this, had been a student of Sue Carter and studied oxytocin in prairie voles. Very interesting model of some aspects of social communication and social bonding, and you can draw connections to human beings. You get a little rush of that oxytocin if you get a good hug from somebody. So that's important for us too, as well as for prairie voles. But no one would want to reduce human loving or human relationships to oxytocin, or at least no one outside of writing a popular psychology book that maybe does a bit of a travesty to the complexity of emotions. So the problem we have is that we have good science going on in these levels, in these systems, and then you can see the columns represent different levels of analysis, going from molecular up to circuitry, which is where the more innovative and excitement is in terms of trying to use brain imaging to understand brain circuitry, all the way up to experience, except that what's there in place of experience is simply self-reports. And that reflects the sort of methodological bias in all this. That's the tool that's used in most experimental studies. You give someone a questionnaire to fill out, or you do a very structured interview and collect information. But that's a very impoverished attempt to get at people's lived experiences. So there's more going on there at the level of experience than simply can be characterized by self-report. And then interestingly, there's nothing else. There's an acknowledgement that, of course, there's a larger environment and context. There's an acknowledgement that there is a temporal dimension to all this, that there are developmental trajectories. But until recently, those were not worked out anywhere near as well as this scheme. So the little oval I wrote there that says social world is what is not developed in the original RDoC scheme at all, and that represents a bias that is very seriously problematic. The question is how to think about that social world. And we've argued that one way to think about it is not just that it's material structures that we're in, but that it is an environment that is full of meaning and full of meanings that are given by history, by language, by social practices, by networks of relationships. And that requires at least as much attention as our search for molecular mechanisms for mental disorders, if we're going to make sense, not only of psychopathology, but even of how the brain works, because arguably, as I'll come to in a moment, the human brain is the organ of culture. It is a big plastic, flexible thing precisely because our task developmentally is to acquire a culture, acquire a language, acquire all the skills and knowledge it takes to navigate a social world. And what's happened as a result of RDoC and other trends that it reflects in psychiatry is that we have a current push toward developing more personalized and precision psychiatry, which will use omics, measuring multiple levels of biological parameters, but it goes on in the context of there being no person in the discussion. What's there is a bunch of biological parameters, and most of the things we mean by talking about a person in terms of subjectivity, in terms of narrativity, in terms of a life world, are not being measured, are not being included in theory building and in explanations of mental disorders. So this is a big problem, a big gap, if you will. And part of what we've been trying to do is collect together the various good ideas people have and things that have already happened in psychiatry to try to make sense of the missing dimensions and to show not so much that they represent an incommensurable and paradigm that is outside this mainstream effort to find mechanisms, but that they can be brought into dialogue and relationship to the mechanistic explanations of human functioning in a way that begins to give us a much more realistic and viable picture of human functioning. So part of the issue, I can illustrate part of the issue with this kind of picture here. I don't know how clear it is. It's a little bit small, perhaps. But this is meant to speak to the question of sort of what is it that we're looking at when we see a person who's suffering in some ways, when we talk to them about their problems. The oval at the top that goes from sort of neurobiological process to illness experience to symptom report represents the kind of naive semiotics of clinical care. Somebody comes to you and they say, I'm feeling hot. And we think, okay, that must mean that there's increased temperature in their body, and underlying that is some inflammation or an infectious process. So there's a kind of linear relationship that makes that self-report an index of an underlying problem. But the rest of the diagram reminds us that everything we know from cognitive psychology, from social psychology, from anthropology tells us that the ways that people pay attention to their body and notice things and interpret them and talk about them are profoundly shaped by other processes, not just by a kind of linear connection between something happens, you notice it, and you talk about it. Prior to noticing it, you are already primed to pay attention to certain things. You already have certain schemas available to talk about it that you've received from your culture, from the situation you're in, from your life experience. And so whatever you end up talking about to the person you see, the psychiatrist or the researcher trying to understand the phenomenology of your disorder, whatever you talk about is already being shaped by those pre-existing structures. So if we don't pay attention to those and study those and understand how they are deployed by people as they try to make sense of things that are going on, we're using a very naive view and a very inadequate view of people's self-reports. So what would a more adequate view look like? This is a diagram that reflects the sort of basic biopsychosocial approach that's been something that George Engel proposed in the late 60s, and that's been a mainstay in medical education since the 70s. And basically, it recognizes that biological systems, including human beings, are hierarchically structured. Big things are built out of little things, and that has consequences for how functioning occurs and where problems can occur. Problems can occur at many levels in this kind of a hierarchy. And while psychiatry has become preoccupied with the lower levels in this hierarchy, the higher levels, that is to say, from brain circuits to the way the brain or the person engages the social world, are also systems that have dynamic properties that can go right or go wrong for people in ways. And so we can think of problems occurring at multiple levels in this kind of hierarchy. And the challenge, just like that RDoC scheme, the challenge is then to add all the missing columns and then to talk about how they might be related to each other. So this is kind of the sort of basic dilemma. And then that those higher levels, that social world, those relationships we have with people are not simply dictated by our biology, although our biology creates possibilities for us to relate to people in certain ways and certain requirements that we have to be able to develop and thrive. But those higher levels of organization, from the family, from the couple to the family to the community that we're living in, are shaped by historical processes that are set in motion through human cultural activities. So this is a summary from this one of the books I showed on culture, mind, and brain, that argues that culture and the brain are mutually shaping each other in a sense, although predominantly it's culture shaping the brain in this instance, on multiple timescales. The longest time scale is just the evolution of the human brain itself, which presumably emerged to enable us to do this highly flexible learning and acquire lots and lots of social knowledge and information and navigate social worlds and large groups and so on. But then for the last 50,000 to 100,000 years or more, we've been developing within niches and social worlds that we ourselves have constructed. So we have a co-evolutionary process. And the most familiar example of that is lactose intolerance. Most people in the world, when they get to their 30s, lose the ability to digest lactose. But people who are the descendants of cattle herders in different parts of the world have mutations that allow them to retain that ability to digest. So milk, sugar. So that is a co-evolutionary process in which the human genome in certain groups has been reshaped by cultural practices. So it's just a very simple and well-studied example. We can presume that there are many other subtler examples going on in which we're being shaped by our environment. And then in addition to those sort of co-evolutionary time scale, we have more shorter time scales, a historical time scale of memories that are passed on from generation to generation, the developmental timescale that we all relive and recapitulate in our own lives, a biographical or timescale of how we construct our own sense of self and a narrative of self over a period of time within a cultural world, and finally contextual processes in which we respond to contingencies and expectations and resources that are available in particular situations. So we've talked about this. Here's again the same kind of idea portrayed more in terms of the time scales involved of this sort of shaping of the brain by social cultural factors. We've talked about this also in terms of culture as representing information and possibilities that are coded or encoded in the environment. And becoming enculturated, learning a culture, learning a language, means acquiring the skill to know how to read that environment and how to respond to the messages, but especially the affordances in the environment. So this idea of affordance is something that's borrowed from the psychologist James Gibson, who argued for the idea that perception is not simply taking in and processing of something, but in fact relating to structures in the environment and the way information itself is already structured such that it gives you specific information that you can work with, that there are particular actions and possibilities that occur due to those configurations of information in the environment. And that loop between seeing what's possible and having a repertoire of things to do is actually basic to how perception works in the first place. So that idea has been expanded to say that what's going on when we encounter a cultural environment is that there are a lot of potential resources there, a lot of ways that we can act, and depending upon what we learn from our culture, we have a repertoire of responses. We can read that environment and respond in certain ways with it. Now, that's a different view of culture than purely a mental representational view. There are mental representations, certainly all kinds of things. There are all kinds of external representations, other things, tools we work with. But this notion of affordances is important because a lot of what we make use of in every day in terms of cultural knowledge and institutions is not something we carry with ourselves. It's something that we rely on other people for. And we rely on a social world that's configured in such a way that we can go ahead and attend to that. We did a study years ago with Danielle Groslo, Vietnamese women who had come to Quebec and who, despite all the public health campaigns, were not breastfeeding their children, even though in Vietnam people would routinely do that. And when we sort of studied why those public health messages were not working for these women, what became clear was, aside from the structural constraints that they had, which were having to work and not having the time and so on to always carry out these health advisements, what was also going on was in Vietnam, in a usual setting, there were midwives who were involved with the birth of a child, involved with sharing information after the birth, and that's how a woman developed her strategy for caring for her child. And in migration, that larger structure is lost. That information is not necessarily available to people. And so even though they may hold on to various cultural beliefs, they cannot put them into practice because the knowledge is distributed in the social world and they don't have access to it. One of the clinical implications of this, I should say, is that, again, as I mentioned earlier, we can't always learn everything we need to know about the life world of someone from them themselves. We need to know more about how things work, what it looks like at home, what it looks like in the community, and we need to piece that together in some way. So it points to the value of ethnography, not just ethnography of what happened over there in Vietnam, but ethnography of people living every day in Montreal or in Paris or in Bordeaux, in terms of what their lives look like. The other point to be made, in a sense I've already made it, and it's here in this article, is that if culture lies largely in the environment, in affordances, in tools, in resources and institutions, the biggest part of that environment for human beings is other people. And so this is a paper that tries to use the tools of computational psychiatry, which again are basically been designed to try to model the brain. In this case, Carl Friston's approach to active inference, which is a useful way of thinking about what the brain may be doing in many instances, trying to predict the world in some ways. And so that when our predictions don't match, that becomes something to pay more attention to and to process more deeply and so on. A lot of interesting ideas about certain kinds of psychopathology have been built on that kind of a framework. This paper takes that kind of approach and says, well, what if the thing we're trying to predict is not just, an object in front of us, but it's other people. And it's what other people think and what other people are likely to do and what we need to know from other people and so on. So, and the notion then is that the actual process of thinking and of experiencing is not something that just goes on in the confines of one person's head, but it goes on in loops between people. So this is a fundamentally different ontology of mind. It says that mind is not confined to the skull. John Blofeld, the Buddhist scholar, once said, the long road starts and ends within the confines of the human skull, but it's a long road, and while it starts here and ends here for one person, it goes out into the world, and it is shaped and reshaped by interactions with other people. So that's kind of the argument that's made in this paper. In a different way than it's been made by many other people. This is not a novel idea in a sense, but to show that you can actually use this very au courant kind of approach of computational modeling and try to model not just one person dealing with a task in front of them or perceiving an object on a screen, but actually people engaging with each other in ways. And the implication again is that that kind of interaction is a loop that could be irreducible to the individual people involved and could be the locus of where certain kinds of human capacities and certain kinds of human problems reside. So you see how we're moving toward an ontology that is more fundamentally social in some sense, and that could be of some use to psychiatry, at least in understanding some of the things that we work with. We've taken this further. This is work by Axel Constant, who's currently a postdoctoral fellow with at Sussex, who showed how you can use this kind of a framework to bring together the thinking of evolutionary psychiatry, which argues that we have certain functions and capacities, and when there's a mismatch between what those are and what the environment demands of us, we get into trouble. At least some problems can be thought of in those terms, but you can put that kind of very simple model together with a view of the structure of the social world, and therefore construct a more complete picture of what could be going on and a different ontology for mental disorders. Again, using the toolkit in this case of computational psychiatry to at least show the possibilities in proof of principle. I should say that that toolkit is not adequate to deal with some of the things we'll be talking about in terms of the richness of history, of the narratives that people work with, of the poetics of illness experience. In principle, it could all be reduced to some kind of computational model, but it is so complex that that is not a pragmatically useful way of making sense of these things. So I view this kind of theory building and showing how things are related in this very somewhat rigorous, let's say, computational approach, more as a proof of principle that then allows us to go about our business of looking more closely at how is history, how is narrative, how is the texture of experience really unfolding for this person, feeling fully justified that in doing so we're looking at things that really have causal efficacy and implications for people. Now, what I've been pointing toward is what we think.
Understand.
Yeah, Siri is not following me properly. I just heard a message from my iPad that it doesn't understand what I'm saying, so I don't know if there's hope for that or not. What this points toward is a kind of meta-ontology for cultural psychiatry, that is to say, a way that we think about what ontology is. You can see what I'm saying, that for me, and I would say in current anthropology, it's not simply representations or models that people have, it's ways of engaging the world, it's practices, it's embodied habitus, it's collaborative activities between people that no one person may fully carry. And so that is a different view of what the cultural and social world is made up of, that demands that we also have a different view of what we're working with in psychiatry. Okay, I'm not going to belabor this. I think I've already said enough for you to get a sense of where I'm heading with talking about culture. It's not simply, the kind of stereotype that, people from a certain part of the world have a certain set of traits or characteristics or practices. It's much more about understanding a world and how it fits together. And when you talk about someone who's migrating, forced to migrate, or the world around them is changing rapidly, then we have to characterize that world and how they relate to it. And so there is a whole language that's needed, both of the structure of that world, which we could call an ecology, and the relationship of the person to that ecology, which has to do with how they relate to their niche and the kinds of interactions they have within that niche and their ability to move across different niches. So you can see how the language of ecology, which comes from understanding how animals adapt to their particular corner of the world and how that world that they're living within is highly structured and has its own dynamics, allows us to start thinking about human social worlds in a much more dynamic way. How does this apply to the clinical context? Well, we're seeing someone comes to see us with a mental health problem, and they present certain issues to us, and we're trying to make sense of those. They do that by talking about things that are bothering them, symptoms they have, worries that they have. We ask them pointed questions about that. And in the process, we try to build up an understanding of what's going on. And the middle oval hill represents that process. Somebody's telling us something and we're asking questions about it, and we're empathizing. That is, we're trying to build a mental model or a bodily feeling of what it must be like to be in that situation. We're using that to ask more questions and try to get a clearer picture. And then we are in tune with that person. We can show them, I think I understand what you're telling me. Is it like this? And they say, yes, you understand me, or they correct us. What we learn in psychopathology is something in addition to that, which is there are things going on. We have mechanistic models. This is a person with psychosis and they're experiencing hypersalience. So when you move your little finger, inadvertently, they suddenly notice that and they're very bothered by that. And they say, why are you doing that? Or are you trying to control me? And that's a very odd thing to say. It's not things people usually say in conversation. And in an ordinary conversation, if someone does that, we would probably be derailed. But if we've learned certain kinds of psychopathology and we're there to have a certain kind of conversation, we can insert that other understanding to fill in the gaps and fill in the ruptures in our tracking of someone else. So that's essentially what we do in learning about psychopathology and getting this toolkit that we have as mental health practitioners, and that enables us to maintain connection with people and to track what's going on better and to be present for them. That's the most basic thing in terms of care, but also maybe to offer specific strategies that help them to understand what's going on and maybe to adapt to it differently. There's a third oval in this diagram, and it represents the other kind of knowledge and information that we're actually collecting and responding to. But in most mental health programs and current training, that's taken for granted, which is there's a huge amount of background knowledge that we're using all the time. Someone says, I'm having a problem at home, and we immediately have a mental model of home based on what we think a home should look like. And maybe we ask a few questions about that, but we fill in a lot of gaps based on our own cultural models and normative models and so on. And the problem is that for most people, most of us, that knowledge doesn't go far enough. When people come from different places, when they live in a different position in society, when they've had different life experiences, that whole realm of understanding social contexts and life worlds may not line up with the view that the clinician has. And unfortunately, in most training programs, I would say to this day, much less time is given to learning about that and learning about variations in those kinds of life worlds than is given to understanding variations in the brain, let's say, or in mechanisms that could underlie psychopathology. And yet we need that to make sense of what people are telling us. And so social cultural psychiatry is very much about understanding that kind of realm of information, the life world, those larger levels of organization of a person's environment, not only to be able to make sense of what they're saying. So when they talk about their family, we don't equate that to our prototypical model of a family. We actually have a more realistic picture of what their family might look like, but also because they're features of that social world that might actually contribute to the mechanisms of mental disorders. And so that's kind of the concern in cultural psychiatry, is how to fill that in. Now, we mentioned already the DSM, which made some significant efforts to try to incorporate this information. And as I said, we're fortunate in having some of the main architects of that on this call today. And DSM-4 and then DSM-5 and TR refined this slightly, but introduced this outline for cultural formulation. And really, this is a set of questions or set of topics to explore to try to characterize some aspects of the social context that someone is living in, and even developmentally, the context they came from, and to put that together in ways that might shed light on the nature of their illness experience, the concerns they have, and the stresses they're experiencing, and even potential resources and ways that they could be helped. Also, there's a last element there that has to do with the nature of the relationship. Any clinical encounter is also an intercultural encounter because we come from different positions in the social world. So reflecting on what that looks like from both sides of the conversation is a very important part of dealing with the clinical encounter and having a relationship and dealing with the power dynamics in that context. The consequence of paying attention to these things is that one might not only have a better sense of what people are talking about and what's troubling them, and decide perhaps that we're misinterpreting something they're saying, and I'll talk in a moment of how we use this to look at the assessment of psychosis, let's say, in primary care. But also, this kind of paying attention to context ends up leading to other kinds of recognition of other kinds of problems. So whereas the DSM, as I mentioned earlier, is very focused on individual problems that can be located within the individual, a conversation with someone about their life world inevitably leads toward talking about certain kinds of predicaments that people have. Yes, I'm having some strange experiences, but this has consequences for how I navigate the world, for how other people are looking at me, for my chance to get a job, for my chance to move on in my life in different ways. And for many people, perhaps most people, we see those predicaments are often in the foreground. They're often the reason that really drives them to seek help, and the criteria by which they would judge whether they're getting better. So we have lots of situations where we give somebody a treatment and say, well, your symptoms are better, but they don't feel they've been helped because we really haven't addressed their larger predicament. And it's a commonplace in medicine that we don't just make diagnoses, we make a problem list. You have diabetes and you need this medication, but you also are poor and you can't afford the medication. So that's also on the list of things that need to be considered. And I think, it's a trivial example. The point is that we need to be making sense of those in psychiatry as well. I've mentioned this strategy in the DSM of having available this outline and now having an interview that lets you begin to inquire into it. And the real point of all that, again, is not just to list things, but to make a formulation, to put it together in a way that says, this is what's going on for this person. We need to characterize that somehow. And this is what we need to intervene in. So the question is, what does that look like? Let me just see where I want to go with this. We're running out of time, and I just want to say a few more things so we can then have a discussion. So let me just skip ahead here. And okay. Well, I'll stay with this for a moment. So as I mentioned, we've used this kind of approach to develop this process we call cultural consultation, where we interview people and explore their life world, both directly from them and from key informants, to make sense of what's going on for them. And that leads to characterizing their problem in different ways. And this is what's sort of fed into this eco-social view that we're advocating now and that I want to outline for you in the next few minutes. I've already set the stage for this by arguing that if we understand people as embedded in a social world, and developing in that social world from infancy or through old age, and therefore dependent on that world in all kinds of complex ways, then what we need to be characterizing are not just individual function, but differences or changes or problems in the dynamics of those person-environment interactions. So what's the right language for that? And we have to find a way of characterizing that. And as I say, the model that we have of the brain that just emphasizes what's going on in the brain is not sufficient because it tends to think that all the action is just inside the brain and we can study that in a scanner. We can give people very simple tasks, not very real world tasks, measure functions, and that's going to give us what we need. And as I say, that's the sort of current scheme we have. You can see here on the left the biopsychosocial approach, these multiple levels. We have the RDoC that I showed you earlier. We have the current sort of multi-omics where we can measure different biological parameters. And all these schemes are similar in the sense that they're acknowledging that there are these hierarchical structures. None of them does an adequate job of explaining how are these different levels related. And that's the main criticism of many of these schemes, including the biopsychosocial approach. So we've been arguing that we have actually a lot of resources available for thinking about how these levels are related. We have resources from psychosomatics research from 50, 60 years now showing psychophysiological processes, sociophysiological processes in which social environment has specific physiological effects, and so on. And we can use current work in cognitive science that understands cognition not as a disembodied abstract computational process, but as a physically embodied and environmentally and socially situated practice. That kind of model, which is biologically realistic, in fact, it comes from philosophers of biology, that model from Francesco Varela and Evan Thompson and others, that model lets us begin to think about what people are actually doing in health and illness. And so we've been using that model to kind of think about these processes and take work that's already gone on in different spheres and bring them together in a more integrative way. So we're interested in how language and experience is embodied. That is to say, what we talk about and think about and hear about affects our bodies. Our body, in turn, is the scaffolding for us to develop self-understanding and self-description. We are always embedded in a certain situation or environment, so you can't really understand meaning and experience without characterizing the environment that someone is in and what they're relating to, what their goals are, what the demands of that environment are. Cognition and experience are enacted, that is to say, they involve taking action on the environment, not simply sitting back and making sense of it, but it's We're trying to survive. We're trying to arrange things in a way that allows us to go forward. And they're extended, and this comes back to this picture I gave you earlier of the sort of thinking through other minds, the fact that we are engaged with all these sort of environmental, material, and interpersonal prostheses that extend our minds. So this leads to what we're calling a cultural eco-social view that draws from many different strands. There's, as you can see here, it's got a strong lineage from many different traditions that can be brought together and borrowed from and put together in meaningful ways. And I'll just use this table to make the point. So this approach shares with the biopsychosocial approach a sort of hierarchical systems view of human beings. But it tries to address the problem not addressed adequately by the biopsychosocial approach of what are the dynamics and links between levels. Rather than just adding things on like a layer cake, the question is how are things interacting? It draws from omics in the sense of saying, fine, it's important for us to know these different levels of what might be going on and how people might differ in terms of their liver enzymes or their brain circuitry, but there are additional levels that have to be added that characterize the social world. It draws from the work in social epidemiology of Nancy Krieger, who's talked about the ways in which the environment is an ecological system that is structured by power dynamics and that those affect people in profound physiological ways. So she has a notion of embodiment that captures part of what we're talking about in terms of the links between social structure and physical events in the body. It draws from ecological psychology, the work of your Bronfenbrenner and others, and as well as the work in perceptual psychology from James Gibson, all of which understands basic human function as being embedded in a social world and in those transactions. I've already said a bit about 4E cognitive science. And the thing that cultural psychiatry sort of adds to this picture is trying to put meaning at the center of this kind of characterization. So what does this look like? Very simply, not so simply. What is going on when a person makes their way through the world? The person is represented by a circle somewhere in the middle there. And they have outward processes of self-presentation and engagement with others. They have inner processes of self-construal and making sense of themselves and developing models and schemas about themselves and narratives about themselves and so on. That process, those sort of things that occur at the level of what we would call a self or a person, inner self, outer person, involve the intersection of processes that are biological, that are represented in the sort of purple ellipse, in the green ellipse, psychological processes, computational processes, other kinds of analogical and imaginative processes that are in the purple ellipse, and social processes that are in the blue ellipse. This is another view of that first slide I showed you of the sort of biopsychosocial approach, but this is flattened out partly to say that these are not simply built on top of each other, they are actually actively interacting with each other in very meaningful ways. It's not that we have meaning over here and we have serotonin over here, and they have nothing to do with each other. We can draw lines between these things, and we can begin to unpack those lines. Now, those lines are not the same. Any of those lines that are represented in this diagram actually represent hundreds or thousands of different kinds of connections. They're not the same in both directions. The way things go from, let's say, psychology to social behavior is not the same pathway that things go from social behavior to psychology. But they are measurable, meaningful mechanisms that we can study, that many of which are being neglected by contemporary psychiatry, which need to be understood. You may notice also in this diagram, there's a little green asterisk in some of these arrows. And that's meant to acknowledge that one thing that's going on in these links is actually a process of a linguistic process of translation, because we are using words and images and symbols to make sense of experience and to influence each other, and we have to understand that contributory to our experience. So this is a key move in this whole discussion, because this is where we can begin to go from the richness of narrative, of poetics of experience, of more detailed phenomenological analysis, and mechanistic understanding, where we try to say, why does this make a difference for this person? Why does this have consequences that are of concern? Traditionally, in anthropology and many other social sciences, people have been very leery about making these connections because of the feeling that we don't generate that kind of knowledge. And while it's true that there are methodological limitations to simply giving a narrative account of what's going on for someone, it's palpably the case that the things that I believe and the things I say about myself, what I think is going on with my illness, has hugely consequential effects. It's going to determine where I go for help. It's going to determine whether I worry about this problem or not. It's going to have all kinds of consequences. So it is not the case that you can simply hive these things off and say, well, that's work over there, that's hermeneutic work for a literary enterprise, and this is mechanistic work for a neuroscientist. In fact, we have to be building these bridges and understanding how these things fit together. So I'll end with one. I think I've gone about a right length of time here, maybe a few more minutes, but I'll just show another diagram that also illustrates the problem, because I called it a simple diagram because compared to this, it's simple. This is a little more realistic diagram of what might be going on. Let's say the example we used in this paper was a woman who is depressed. And she's lost her job and she's depressed. So we want to start saying what might be going on that's contributing to her state of mind and her difficulties. And we have a lot more to say about all the different things that are going on in terms of her brain functioning, and in terms of her psychological processes, and in terms of the social processes that have excluded her from work and are affecting her self-esteem and affecting her options for getting back to work and determining what level of social support she has, and so on. So drawing the picture this way, rather than focusing in on what's happening at serotonergic synapses, is insisting on a different ontology for psychiatry. It's insisting that the problems we're trying to understand, the problems that people are bringing to us, are larger and more complicated. And even if one of our contributions, let's say in psychiatry as a profession, is we have a certain toolkit that's been developed, we have to ask ourselves honestly whether that toolkit is fit for purpose. And whether we're like the proverbial person with a hammer for whom everything is a nail. So we can write prescriptions, so everything gets a prescription. If we know CBT, everything gets CBT. If we know family therapy, maybe everything gets family therapy. But maybe what we really need is a much more differentiated toolkit, and at least a conceptual model where we can acknowledge our limitations, we can acknowledge when we haven't captured what needs to happen, and when we can direct people toward the kinds of resources that are genuinely helpful to them. The practical challenge in this, and where our current work is sort of situated, is trying to deal with this intrinsic complexity and figure out better how to simplify in a way that makes sense. We all do this, of course. We all have, anybody who's a clinician has to do this. You have limited time, limited resources, limited information. You have to decide, here's a reasonable place to begin. But hopefully you have the humility to say, I know I've only got a little piece of the puzzle here. And if it's not working, what you proposed, instead of blaming the patient, which often happens for not wanting to get better or not following the prescription, we reinterrogate ourselves and our model, and we enrich it in some way till we have a better description of what the problems are and what's going on. One consequence of this, I think, the other point I guess I want to make about this diagram, I've mentioned these asterisks again that represent sites of linguistic mediation, but this is also a causal loop diagram. And unlike the diagrams that are typically used in epidemiological research, as acyclic graphs, where it's very important that arrows only point in one direction and that they don't come back to loop back on themselves, the real world is not like that. The real world and real biological systems are full of loops. And as the physiologist Dennis Noble has pointed out, when you have these loops, when you have multiple loops in a biological system, causality can begin anywhere in the loop. In the end, it feeds back on itself. So to give a causal account, to say, oh, it's disruption in serotonin transmission, and that's why you have depression, could be no more accurate than saying, well, you lost your job, and that's disrupted serotonin transmission, and that's why you have depression. if that's even the loop. I mean, we can debate whether that's the proper loop. So that's one point then, that if we have these circular dynamics, we have to think in more systemic terms. And crucially, and this is where we can begin to learn from current work that's going on in systems biology and systems medicine and so on, that these kinds of loops have particular dynamics. They can show a sensitivity to initial conditions, so that a very small deviation can become amplified dramatically and go off on a very different trajectory. They can show convergence, so that even when there's a big perturbation, things come back to where they're supposed to be. That's a lot of what homeostasis, the kinds of things that Claude Bernard originally noticed, are important. So understanding those kinds of dynamics opens the possibility, again, of having a much more accurate picture of how illnesses and symptoms unfold. The tools we have now from network theory allow us to begin to study that. If we look at that over time, and if we build models of how things could be interacting, those models, as I say, can include language. They can include people's self-understanding. They can include the responses of others. And that can become part of our picture of what a problem is. To me, this is a picture of psychiatry that gets quite interesting and quite close, I think, to where many of us practice anyway, even though it's not formalized. We have this simplified diagnostic toolkit, and we often use more complicated pictures of what's going on in a person's life to guide our intervention. This is a model that we've used in writing about somatization and somatic symptoms, and it applies really to any symptom that people experience. It's similar to that diagram I showed you earlier in the semiotics of medicine. At the top are places where different sensations or perturbations or feelings could come from, changes in the body, illness, and so on. Then there are attentional processes. Are we noticing these things? Where are we looking? How do we direct our attention? Then there are interpretive processes. What do we attribute things to? How do we make sense of them? And then at the bottom in the pink box sort of are social processes. So this is, again, just a simple description of what's likely going on when someone, has a headache and decides what to do, or talks to somebody else about it, or goes to see the doctor for their headache and so on. Because there are loops between all these levels, problems can become persistent because of a loop. And the best examples in psychiatry, psychology are things like panic attacks, where you feel distress, you interpret it as something very serious and life-threatening. You get more anxious, you have more symptoms. You feel more tightness in your chest, or more tingling in your fingers, or whatever, and you go into that kind of a loop. So it's a simple example. There are all kinds of cultural variations in panic attacks based on specific cultural beliefs that people have. Devin Hinton has described many of these in Southeast Asians. What it implies is that we could have a psychiatric nosology that is not about discrete entities, but is about particular kinds of loops. That we could say, we already do this, as I say. I mean, a cognitive behavioral therapist will say, well, there are certain loops that are somatic, emotional, cognitive, or attributional, and that's the vicious circle. And I can intervene anywhere in that circle to begin to break up the problem. So could we develop a typology of loops where we have many more other kinds of loops? Social withdrawal leads to lack of social reinforcement, leads to more depression. And so on and so forth. So this is just a list of some simple loops that are documented in different ways. They're hard to study, because especially social loops, because it's hard to do social experiments, but they're natural experiments that have occurred that show some of this. And it would lead to a different kind of nosology, arguably one that makes more sense in terms of what's really going on, what's making problems severe, and where do we get leverage to make a difference. So I don't know how I'm doing with time. I think I could stop here. I can go a little bit further. It's really, let me know, because I've sort of lost track of time. Maybe I'll use these. I think two more slides and I'll stop. So this leads to sort of a question. So if this is a realistic picture of what's going on, we have this problem of how do we actually practice this? And again, I would say many of us already do this to some degree in everyday practice. That is, we're making a diagnosis, but we're also thinking, what are the contingencies around this person that are making things worse, making things better? What can I mobilize to help them cope better, et cetera, et cetera. So it's in that problem-solving way, we're already thinking in this more ecological, interactive kind of frame. But we could be more systematic about it, and we could insist on making more comprehensive lists of problems, not just saying once we've made the DSM or ICD diagnosis, we're done, but rather, being more responsive to the predicaments that someone is dealing with. And giving equal attention. And Juan Mezich has led a process of trying to develop person-centered integrative diagnosis that insists on balancing attention to pathology and vulnerability with attention to health and resources and resilience that can be mobilized. So we sort of do this, but it's not formalized to the same degree in mental health practice. And we could say that a formulation is not just a simple diagnosis or just a purely psychodynamic or psychological characterization, but it involves characterizing some of the embedding in a social world and some of the loops that may be aggravating or stabilizing or ameliorating a problem that someone has. So we would end up with a more eco-social formulation that would give us better understanding of the processes of chronicity, more potential targets for intervention, more resources to call upon, and a much, I think, richer and ultimately more effective way of understanding problems. This would lead to a different kind of research program, different kinds of work that needs to be done to develop these ideas and to show that they make a difference in clinical cases. So that's the slide on sort of these clinical approaches. So let me end. I said I was, because we're in a certain moment here, let me end with this brief comment on the fact that the social worlds we're living in right now have changed dramatically in the last couple of decades. People get most of their health information from the internet. Come to the clinician already with lots of ideas about what might be going on. Maybe they found a self-help group where people were talking about all kinds of things and they found exact words that they're using or feel fit very well with what they're going on. And we have to engage with that. And those social worlds, those social environments, the internet, the social media and so on, represent a new kind of ecology, new kinds of circulations of information within the niches that people occupy. And they extend the niche so that it's not just who's next door to me that I talk to when I go out in the morning to go to work, but who is who's in my bubble, who's in my network. And we're at a moment where, because of the structure of those networks, which originally were imagined as being a kind of open frontier that would just put everybody together and we would all be happy and we would have Arab Springs and everybody Springs and it would all be great. And now we see are being capitalized and controlled to institute really oppressive agendas. So making sense of how that works and how misinformation and disinformation are not just accidental consequences of creating a global agora where everybody has a megaphone and everybody can shout loudly what their own view is, but actually being manipulated and controlled in ways that ensure that we only talk to like-minded people, that we are exposed to lots of frightening things, although there are plenty of frightening things to be frightened about, and that the global agora, the kind of common civil space that we need to have community, that we need to have deliberative democracy, is being eroded and co-opted. So this is an important reality for mental health practice. Something we need to think about is how our sources of information and how our ability to predict the environment are being altered by these ecologies. And I think mental health practitioners, first of all, in terms of understanding the suffering of the people we see, but also perhaps contributing to understanding the political moment, need to pay attention to this larger social world. It's not just about the narcissistic personality disorders or sociopathy of certain prominent leaders, which don't require much training to recognize, but it's also about how things are being wired together and how that's being capitalized and controlled to meet the interests of a small number of people. So I think this is a new ecological reality. It's reflected in all kinds of social adversity that people are facing. Some of our work is with migrants who are currently under siege in many places in the world. And we need to push back against those things if we're going to have a global civil society that allows people to flourish. So I got my little editorial in. Not any answers, but at least naming the problem. So hopefully we can talk a little bit about it, or part of the problem. If you're interested in this stuff, I'll do the other commercial now, which is we have an annual summer program where you can get a whole month of this kind of conversation with people who come from all over the world to talk about this. And we also have there's a month-long course in cultural psychiatry. I think I have a list of the courses here. Um, month-long course in cultural psychiatry and in working with culture, and then week-long workshops in art and healing and contemplative studies, culture, mind and brain, global health, indigenous mental health. And we have an advanced study institute this year in June that's a more focused, intensive discussion on a particular topic, and this year it will be on cultural configurations of the self. So I will stop there. I think I've gone quite a bit over, actually. Apologies for that, but I got my last couple of things in. So.
Merci beaucoup, many thanks, dear Laurence, for this panorama, cette vue globale de votre pensée et de la manière d'aborder de manière éco-sociale la psychiatrie. Donc c'est maintenant le moment des échanges et de pouvoir interagir avec vous pour pouvoir vous poser des questions et avoir la
Donc,
prochaine
on vous
échange.
demande de lever la main et Jean-Arthur fera la régulation. Comme on disait, on va peut-être essayer de favoriser dans un premier temps les étudiantes et étudiants du DIU et puis ensuite on pourra échanger tous ensemble.